Susan, would you like to do the introduction of our guest speaker?
Certainly, Mr. Chairman. We have Dr. Danny Avula here in the room with us, and Dr. Norm Oliver, the State Health Commissioner, is also available if there's questions that come up that he can answer as well. But Dr. Avula is going to take us through the slides, and I'm going to put those up right now.
Thanks, Susan, and good afternoon, everybody. So I was asked to give an overview of where we are with vaccination efforts here in Virginia. Susan, do you want to, put those to slide mode. Some of you actually heard some of this last night. I presented to the House Republicans and spent some time with the House Democrats a couple nights before that. Didn't have slides together, so hopefully this will just kind of solidify the things that we were already talking about, and obviously answer any questions that you all may have. So the data on that first slide was data from yesterday. Today's data, I just want to say, has been updated. So our total doses administered, 424,857. So just shy of 425,000 doses. Our total vaccine doses distributed are just over 1 million. So 1,010,150. So some slight updates from the slides that you all are seeing right there. If you could go to the next slide, Susan. So I've organized sort of our thoughts about how this vaccine campaign is really laid out. And there's kind of three main areas that we're really focused on right now. So as you just saw, and the numbers that I just shared, that 425,000 doses administered and just over 1 million doses distributed, there's a pretty large gap, right? Almost 600,000 doses that are not accounted for in these data. And that gap has driven a public narrative that there is just vaccine out there that's being mismanaged. There's vaccine out there that's sitting on shelves. How come we can't get this vaccine into our people? And so I think it's really important that we, one, have the highest priority on closing that gap and making sure that there isn't vaccine out there that should be in people, but two, really helping the public understand the data and what goes into that gap, because there will always be some gap, right? When our number just went up over 1 million today because we got new deliveries yesterday of vaccine around the Commonwealth, we're going to have about a week to go through that and set up our events and get the vaccinations done and get those administered into the system. So, to some degree, there is a lag that we will always expect of probably about 200,000 doses that'll get updated by the next cycle. But so that this concept of closing the gap is really one of the big areas we're focused on. The second area is really managing the present, right? We have a pretty significant supply and demand mismatch right now. We're only getting about 105,000 doses a week, and we have much more demand than that. And so I'll talk you through that. And then the third bucket is really around building for the future goal of 50,000 doses a day, because we need to hit that mark to be able to get most of our population vaccinated by midsummer. And right now, that is just a hope, because we don't have anywhere near that amount of vaccine flowing into our community. But we've got to be ready when vaccine production scales up and we have the ability to get 50,000 doses a day through multiple channels. So I'll talk us through that. So closing the gap, fixing the supply demand mismatch, and then building the infrastructure for the future. So next slide, Susan. Let's talk through closing the gap. So again, these numbers are just a day old, but what you'll see here from yesterday's numbers, the total distributed to Virginia, 960,000, total administered 400,000. So there's a delta of about 560,000. And so where is that vaccine? What are we doing with it? So about 90,000 of those doses are actually doses that have been administered, but have not yet made it into our state database, the Virginia Immunization Information System. And a couple primary reasons for that. One of those reasons is that in certain parts of our state where we were doing large scale mass vaccination events in places where we didn't have very reliable internet connectivity, our local health departments and other partners that were doing those types of vaccination did paper registration. And so in different parts of the state, there are a few thousand paper registrations where the vaccines have been given, but the data hasn't been entered. We are resolving that this week. We put together a team of people who can enter that data into the state database. We're dispatching them out to the districts. We had a team that went out to the Peninsula Health District yesterday to help them caught up. And we've got a couple more of those that are going to be working through the weekend to make sure that this gap closes by that manual data entry. Now, there's another large segment of this vaccine, that 90,000 dose data disconnect, where the different platforms that different providers use when they register patients have not had a clear connection. The vast majority of our platforms do. So when you think about the health systems using Cerner and Epic, and then even smaller systems using different types of electronic medical records, we have used VIS, the immunization database, for years, and we've built those channels over time. And so there's good data porting that happens to VIS. But in about 58,000 cases, there were hospitals that were primarily focusing on their own populations, because that's who they were vaccinating first. And they, instead of using their electronic medical record and registering people as they would their patients, they used their occupational health records, which did not have clear ties to VIS. And so we have onboarded a data team over the last week that have been working with these individual providers, trying to figure out what are the software fixes. Tonight, we anticipate about 35,000 of this total data gap will be resolved through some of these software data fixes. But it's not just one software data fix, right? It's a different software fix for each of these platform mismatches. So there's a big chunk of this that, again, the vaccine has been administered, it just has not been recorded, and we should resolve that by the end of the weekend. Now, the next part of the delta that you see there is 78,000 doses from long-term care facilities. And that number might be a little higher, but basically the federal government's plan to vaccinate our residents and staff of nursing homes, assisted living facilities, and independent living communities was to contract CVS and Walgreens. And they have allotted a total of 226,000 vaccines to that group. And they are drawing that vaccine down at different rates. So right now, of that total 226 allotted, there's about 128,000 that have been delivered to Virginia and count in our doses distributed. Now, of that total, did I say 108? It's 226 minus 100. So 120, 128 is what I said. So of that 128,000 that's been delivered, at this point, only 46,000 today, have actually been administered in those long-term care facilities, in those residents of nursing homes and assisted living facilities. We have been actively pursuing CVS and Walgreens. We've given them just a sense of urgency that we have got to get through our first doses in this priority population by the end of January. CVS has assured us that they've already gotten through their skilled nursing facilities, and they will have their first pass of all their assisted living facilities by February 1st. Walgreens is trying to accelerate their timeline. They started a little bit later, so they're trying to see what they can do to bring staff together. But what we have told them is, listen, if you guys can't get to these facilities by the end of January, then we're going to need to reallocate that vaccine to other pharmacies and other providers who can deliver that over the next 2 weeks. So part of the way that we're going to close this gap is by reallocating vaccine that is currently earmarked and being held by CVS and Walgreens to other facilities, to other pharmacies, to be able to get through the long-term care facilities more quickly, really get that first dose passed by the end of January. Now, here's a big one. As of yesterday's data, and this is probably a little higher today now that new distributions have come in, our health systems, remember, were the recipients of most of the vaccine up front. And so what happened is, when we started this effort and we were in 1A, which was healthcare workers and long long-term care facilities. The federal government was approaching long-term care facilities through CVS and Walgreens, and we were allocating to hospitals and health systems to do their healthcare worker populations. And we allocated 100% of their requests. They basically asked for doses for everybody who works in the health system who would qualify as 1A. Now, what happened was that we didn't have 100% uptake. So in many of those health systems, we had about 50 to 60% of the healthcare workers who actually wanted to get vaccinated on that first round. And so hospitals did that. They did it very efficiently. If you look at our data, you'll see that the largest part of our total doses administered, so today of that 425,000, 208,000 of those doses have happened in healthcare systems. And so they've been fantastic in terms of getting their population vaccinated and vaccinated quickly. Many of them are now on their second round with those healthcare workers, but they have also held on to a lot of that vaccine because they've been kind of focused internally on their staff. Now, that's not true across the state. There are a number of great examples where health systems vaccinated their staff and then said, okay, how can we now turn externally and help vaccinate other healthcare providers in the community? There are other parts of the state where that hasn't happened. And so you probably have heard from many doctors and nurses and other types of healthcare providers in the community who are saying, I don't know how to get vaccinated. And so we are really trying to steer those folks to health systems, but also to health departments to ensure that those other 1A populations get vaccinated. So, part of our strategy too with this is both helping our health systems understand that they will get second dose allocations, right? And this has already started to happen. The way that the federal government is dispersing vaccine, they direct ship second doses to the people who received it on a schedule. So if you are a health system in Danville and you got 10,000 doses of Pfizer, 3 weeks later, you will get 10 more thousand doses of Pfizer because the Pfizer vaccine has to be given 3 weeks apart. Similarly, if you're a large multi-specialty group in Tidewater and you have 5,000 vaccines, you're going to get of Moderna, you're going to get 5,000 doses of Moderna 4 weeks later because that's the dosing interval for Moderna. And that is happening through direct shipments from the federal government above and beyond our weekly allocation of 105,000 doses a week. Now, this has been a point of confusion, and I think a lot of our health systems either didn't understand that or didn't trust it, right? I think we've heard so many mixed messages and uncertainty around how vaccine distribution is happening at the federal level that a lot of the health systems have said, okay, we're going to have to hold on to this vaccine to make sure that we can get second doses in our staff. And so a huge part of our gap of this, 600, almost 560,000 dose delta is doses that hospitals have. And some of those are accounted for, right? Like they have set appointments for second doses, but they will be getting more second dose vaccine. And so part of our allocation strategy moving forward is really working with our health systems to get that vaccine where it needs to go. In some cases, the health systems are actually incredibly well suited to deliver that to our priority populations, right? They see tons of people who are in that 65 and up and folks with underlying conditions and should absolutely vaccinate those populations. But in other cases, our hospitals and health systems are really struggling right now, right? Like we've seen so much COVID hospitalization, particularly in parts of the state like Lynchburg and Roanoke, but really the entire healthcare infrastructure is under a lot of weight to manage their acute care responsibilities. And so in some cases, health systems have said, listen, we just do not have the capacity or the staff to be able to vaccinate externally. And so in those cases, we are connecting the dots, linking hospitals with other providers, with local EMS, with health departments, reallocating that vaccine. And so that will be an active part of our work as more and more second doses come into Virginia. And then that last piece is other providers. So in the same way that we have a large amount that is sitting in hospitals, we have doctors' offices, pharmacies, and health departments that account for some of that other vaccine. Again, a good chunk of that is slated for administration in the upcoming week. And so hopefully that breakdown again is helpful for you all to understand that this is not an issue where we have tons of vaccine just sitting out there. In fact, it's quite the opposite, where we have very little vaccine coming in and way more demand and desire and capacity to get those vaccines out. All right, next slide, Susan. So what are we doing about this? I've kind of mentioned this already, but that first is really the data fixes. We're sending teams. We're trying to get the data to connect. So that's how we're going to close the gap. The second is reallocation. We really need to move the vaccine from the health systems and providers that aren't moving it fast enough. We need to move it to places that can get it out and can get it out quickly. This morning on the phone, the governor with all of the local health department directors and all of the health systems said, you know, we got to use what we have. Otherwise, it's going to challenge our ability to bring new vaccine in each week, because at some point the federal government is going to have to say, if you're not using it, we're not going to give you more. And so I think it's very clear at this point, and I appreciate the CEO of VCU, or the head of VCU Health System, Art Kellerman, who said, hearing the message loud and clear, we are going to, we're shifting to do our priority populations, and we're going to work with our partners to get vaccine out the door. I think that's exactly what every health system needs to be in the mode of. No longer can we hold with uncertainty the vaccine for our staff. We need to trust that we're going to get these second dose deliveries. We've got to move it into communities. And then the third piece is connecting the dots. And I mentioned Danville before. On Monday of this week, Sova Danville said, we've got about 7,000 doses. We've finished our staff. We really want this to be made available to the community, but we are under a lot of weight and don't have a lot of capacity to do that. So we got the executives from Sova Danville, the health director of that community, the city manager of that community, and the president of Averett University. We brought them all in a room and said, listen, we have all of the pieces here, right? We've got vaccine, we've got space, we've got vaccinators through the nursing school at Averett, we've got the infrastructure that the local health department provides around registration and data entry and kind of plans around throughput. And now they've got a 1,000-person event that's happening tomorrow. And so it's that kind of dot connecting that we're trying to facilitate in different communities to make sure that they understand they do have the tools to get this done. And they just need to kind of figure out the nuts and bolts of getting vaccination off the ground. And so we're setting up those tables in different parts of the community. Next slide, Susan. So the second body of work is then navigating that gap between supply and demand. So, what's driving this gap? One, 105,000 doses a week, right? We have extremely limited supply. I think I mentioned last week we had almost 300,000 dose requests, yet only 105,000 doses to dole out. Now, the gap, why is there so much demand? We started 1A, worked through 1A in many communities. And then what we saw in certain parts of the state was that they were able to saturate their 1A demand fairly quickly. And so we didn't want to restrict those parts of the state that were able to do that. And an ability to do that was based on a lot of different things. It was based on, how much capacity there was to vaccinate between the health systems and health departments, but also based on how many 1A residents were in that community. So, Southwest Virginia, as an example, just didn't have as high a concentration of healthcare workers or other people who would have qualified for 1A. So they got through their 1A demand fairly quickly. And so in the vein of giving people flexibility to move forward, to get vaccine out to other vulnerable populations, we moved into 1B. Shortly after that, we were getting guidance from the federal government that said, in this 1B category, you really need to be adding 65 and up and those with underlying conditions. And to meet that priority and to meet that demand, we are going to release our second dose reserves. We're going to put a lot more vaccine into communities. And so we, as Virginia, saw that guidance and said, okay, if we've got more vaccine coming and we know that those folks are also at risk, we're going to move those 65 and ups and folks with underlying conditions into group 1B. But what it did is it created a ton of folks in that now 1B category by adding this. And so that number is over 4 million Virginians that are in that 1B category. And so that has created a tremendous amount of demand. And then, when we made the decision to go in 1B, and then 24 hours later, the federal government said, actually, those stores don't exist. You should anticipate that you will continue to get the same weekly allotment that you've been getting. We were really disheartened by that, right? Like, okay, we were expecting much more. We expanded 1B as the federal government advised. And now we're in a situation where we're still only getting 105,000 doses a week, but we have 4 million New Virginians that are trying to figure out how they can get vaccinated. And so that is driving a lot of angst and frustration, understandably, right? There are so many people who are saying, I'm in 1B, why can't I get vaccinated? And that's the challenge that we're facing now. Next slide. So what do we do with this allocation now? This little chart, and we have this broken down by district, but I just did this for the sake of the slide. We're doing geographically driven distribution. So you take each district, and we're doing that primarily by health district because we're really leaning on the local health directors to drive the allocation strategy in their district. But so, for example, the Richmond Health District has 3%, a little less than 3% of the state's total population in Richmond City. So they will get a little bit less than 3% of the overall allocation of vaccines. So less than 3% of that 105,000. Chesterfield has about 5%, and so they're going to get 5% of the total allocation. So that's how we're defining allocation. And when you start to look at the numbers and start to break them down, you realize that those are really small pots for communities all over the state. And so previously, when there were tens of thousands of doses going to health systems at a time, and now there are 1,000 doses at best, maybe, that are going to a health system each week. Hopefully that helps you understand why the health systems have expressed so much frustration, because they helped by scaling up and doing mass vaccination. They have the capacity to do it, but there's just not the vaccine supply to kind of feed that machine. And so part of my comments to the health systems this morning were really helping them understand, like, we need you. We need health systems as part of the long-term solution. But right now, this is that there's just not enough vaccine to infuse into that channel. And so, I'm hoping that our health systems will recognize that they do play an important part. They will be really relied upon once vaccine supply increases. But for now, that they should think about how staffing, allocating their staff elsewhere. Next slide. I walked through some of this already, the 1A, 1B, and sort of why 1B is so big. But I think I want you to see, and I think this is on the next slide, Susan, if the 1B category is a lot of different essential workers. So, and the goal, when this guidance was put out by VDH, the goal was to work through those 1B essential worker categories systematically. So you would start by focusing on police and fire and hazmat. You would then progress down to the next category, which I think is, it's super tiny on the screen, but I think it's corrections and homeless. The next category is teachers and childcare workers. But if you look at those bottom 9 bullets, that kind of gives you a sense of what are the tiers, what is the process that we're going to go through to vaccinate these different groups. And so what health departments have had to do with very limited vaccine allocation is figure out, how do we simultaneously prioritize individuals who are 65 and up and have underlying conditions and these essential worker groups. And they've all kind of done that differently. So in some districts, they've said, all right, we're going to push some of this vaccine out to the pharmacies, and we're going to ask our 65 and up population to go to our pharmacies. And we, as the health department, will continue to focus on police, fire, hazmat, and work down this list and do closed pods. And when I say closed pods, what I mean is that a health department will reach out to the police department or anyone else who falls into that category, and they will say, hey, we're going to set up a pod, a point of dispensing, an opportunity for this group of people to get vaccinated, and we're going to register all of those police and fire and do them at one time. So that's the strategy that most communities have been using, where they're simultaneously trying to do 65 and ups and underlying conditions, as well as working through those essential workers. But again, as you now understand, there are many, many, many more people in 1B than can get vaccinated. And so and we have to do a better job of the public messaging around this. We have to make it clear to people in the public that not everybody in 1B is eligible all at the same time. And realistically, if we're looking at the number of people in 1B who want to get vaccinated and the amount of new doses that we're getting each week, we're talking weeks and weeks. I mean, probably 3 months before we're working towards the bottom of this 1B list. And so we've got to be clearer about managing those expectations. And I think some of the variances in how districts have handled this as they work with their local partners and have the different pressures of a local government that says, hey, we need to get our teachers vaccinated immediately. Everybody's sort of getting pulled on in every direction. And so even though these guidelines have been laid out, they may not always be followed to a T, and that has created some of the frustration that we're hearing from different groups. So what's the solution there? I mean, I think we are going to need to kind of reevaluate based on the data who's vulnerable, and this has been vetted really thoroughly by VDH and an entity called the VDMAC, the Medical Advisory Committee. But given this existing supply-demand gap that we have and the fact that it does not look like that's going to change significantly in the coming weeks, I think we're going to need to revisit this 1B strategy and really be much clearer about who we're prioritizing and at what point. Next slide. All right, so the last bucket of the work is really in building the infrastructure for 50,000 doses a day. When you take the adult population of Virginia, approximately 7.2 million or so, actually a little less than that, but you take the adult population of Virginia, you know that you need to get to about 70 to 80% of the population vaccinated to create some kind of herd immunity that's going to stop the transmission of COVID. And we know that this is a 2-dose vaccine. And so when you take the total number of vaccinations that needs to happen, we really are going to need to get to 50,000 doses a day to be able to get through our population by the summer. Now, how are we going to do that? Next slide. We've got to do that through multiple channels, right? So right now we're primarily leaning on health departments and health systems to do the bulk of our vaccination, but we're going to have to open that up to other channels. And so we have been in the process of onboarding physician groups, of onboarding pharmacies. Right now there's over 2,000 physician groups that have become approved CDC vaccinating sites, about 400 pharmacies throughout the Commonwealth that are approved vaccinating sites. And so we're going to need all of these pieces, the hospitals, the health systems, the health departments, pharmacies, and physician groups. But that may still not be enough to get to 50,000 doses a day. And so we are also implementing plans for fixed site vaccination. We've identified about 12 sites across the Commonwealth that have kind of that are centrally located enough and have a large enough population density where a National Guard staffed vaccination site 6 or 7 days a week that can churn through 1,000 to 2,000 individuals a day. So that will be ready to go when we have a big influx of vaccine. Like right now, we don't need that. We don't have enough vaccine to even make that useful at all. What we do have is health departments and health systems that are collaborating to do large scale vaccination around the state, typically once or twice a week as vaccine is available. But what the National Guard will be, and VDM and VDH are basically piggybacking off of some of those sites. And as vaccine becomes more available, we'll be able to staff up in a consistent way 7 days a week to provide the level of volume that we'll need. And so, at this point, when do I anticipate that'll happen? Probably not until late March, early April. I think the things that will change vaccine supply, perhaps there will be some additional production that happens with Moderna and Pfizer as they scale up their manufacturing capacity, but really it'll be the entry of new vaccine candidates. So AstraZeneca, Johnson & Johnson are both in the final phases of their vaccine trials. As they get through clinical trials, submit all that data to the FDA and try to get their emergency use authorization, we're looking at least a few weeks, probably end of March, early April, before some of that vaccine is actually available. So, this is the forward-facing plan of how we get to that 50,000 doses a day. Okay, I think that's the last slide that I had. Is that right, Susan? Yeah. So let's pause there and see what questions you all have.
Okay, thank you, sir. Thank you so very much for your presentation. And at this time, if you have questions, just put up your little hand on the so I can see you on the screen, please. If you have a question for Dr. Abula. I think Delegate Aird may have a question or two. And then I see Delegate McQuinn.
Thank you so much, Mr. Chairman, and thank you so much, Doctor, for the presentation and, quite frankly, the work that you have done to date in trying to give us an update on where we are. If it's okay, I have a few questions. I will try and ask them as succinctly as possible and then give you a chance to respond to all of them at once. First, you have touched on a number of things in your presentation, but quite frankly, it was a lot of detail. And so I'm just hoping we can unpack a little bit of it. I'd like to start with the fact that there's something I'm deeply concerned about, which is the disparity in which access to the vaccine has been rolled out. Particularly, I represent the Crater Health District, which, if you don't know, is a region in which has some of the most challenged social determinants of health in the Commonwealth, but furthermore has some of the lowest health rankings and standings in the Commonwealth as well, particularly Petersburg. Right now, I'm hearing that the Crater Health District is one of the only in the state that remains in the 1A phase. More specifically, I am being contacted about healthcare workers that can't even get the 1A that in the 1A category as they should be allowed to. And so I'm deeply concerned that we have communities like mine where they are already in a worse standing, considered to be a vulnerable population. And they are far behind and backlogged more so than many areas around the state. And so I really would just like to know how we're going to address this type of disparity, because I only see it growing over time if it's not deliberately targeted. That's one question. I'm just going to ask one more and then let you respond. In addition to that, I also, again, represent a community, Chesterfield County. You mentioned some of this in your comments around teachers wanting to have access to vaccines before they go to school. And specifically in Chesterfield, they were all but promised that by February before their return to the classroom. We see this popping up all over the place. My office has been contacted because not only are they not getting those vaccines there, but I'm hearing that in a neighboring locality in Dinwiddie they are, in Petersburg they are not. And so I'm deeply confused about how this process actually should be working. You stated in your comments that the variances between how these health districts have rolled this out has created confusion. And it's almost as though they are being slated to be at fault a little bit. But quite frankly, I just feel like not only am I seeing just the entire process not being consistent and not being equitable, the communication around what citizens should be expecting is unclear. We have not.
Delegate Aird, let the doctor respond to your questions, please, so that we can move on to a few others.
Thank you,
because we are going to take questions up until 2 o'clock. So we need to be succinct in our questions to Dr. Abula. So please allow him an opportunity to respond.
Thank you, Chairman, and thank you, Delegate Aird. I will do my best to get to all that. You are 100% right that the communication has been unclear. Part of that has been that things have changed every day, and we're like pivoting, based on new information, based on new guidance from the federal government, based on new understandings of how our vaccine is going to come and how it's not. But we need to be able to communicate that more clearly. I think when in our conversation with both the caucuses over the last couple of nights, one of the things that clearly came up was a need for just a written update twice a week that would come to you all, and that you could share with your constituents. It would both keep you in the know about where we are with the vaccination effort, and help the public understand where we are. So here at 100%, we've got to do a better job of clear communication. We'll work on that by equipping you with that information, but also, we're doing twice weekly press briefings. A good chunk of my time is kind of helping provide the media what they need, and so using some of those traditional channels to get the word out. But every channel that we can possibly use, and when you all start to receive those from us this week, if you could continue to push those out through different networks. But we need to do a better job of communicating to the public what the expectations are. The teachers by February, I think that again, a lot of folks were anticipating that we would have a lot more vaccine available to us than we did, and frankly, I don't think we can do the teachers by February unless things change significantly in terms of vaccine supply, or Chesterfield basically says we're going to do this instead of our 65 and up population. And the guidance that we've given from the VDH level is that we've got to try to do both. We've got, with the small amounts of vaccine that we're getting, we've got to try to meet all of those competing needs. So again, for Chesterfield, we're looking at 4,700 doses this week, and so about half of that should ideally go to the 65 and up and underlying populations, and half of that should go through Chesterfield's work with those remaining healthcare workers in 1A who haven't been vaccinated, and then on through police and fire, et cetera, et cetera. For the Crater Health District, their allocation is about 1,800 doses this week. And again, this is really based on percent of the population. And then it's up to the local health districts to define how are they going to address some of the access and equity challenges in their own community. I will say that Crater has in comparison to other health districts, is underfunded. And so they have not had the staff capacity that is needed, frankly, for an effort like this. And so we're trying to figure out how we can support them in every way possible. And earlier this week, I facilitated a meeting with Bon Secours and with the health district. We brought HCA to the table as well because they own John Randolph. They are looking at how they can deploy more of their vaccine down to the Petersburg area and create more opportunities for those communities. And I think, for you all, that local facilitation is a place that I think you all can be incredibly influential, right? We have these health systems that have a fair amount of vaccine. We have, the local governments that can provide space, and we have the health departments that can find vaccinators. And so by putting all of those pieces together, that's how we're going to get this vaccination effort off the ground. I think to think that our local health departments are able to do all of this by themselves, this is the single biggest response that we've ever been involved in, and it's really going to take the coordinated efforts of entire communities to get there. So I think any way you all can be helpful in that. The Crater Health District has moved to 1B. They've been starting to do 1B populations while continuing to do 1A. So just know that. And by Monday, every district in the state will be fully in 1B. I think the disparity in vaccine access, I think you're speaking both geographically, but also I would guess racially as well. And so we are very cognizant of that. One of the big gaps in our data right now that we have to improve is the collection of race and ethnicity data. And so that will continue to help us. And right now, a lot of that has skewed to the elderly in nursing homes and to healthcare workers who skew towards a much wider population. But as we open up and get deeper into 1B, we need to have a lot of clarity about how are we ensuring that the populations of color that really have been more affected by COVID, more severely affected by COVID? How do we make sure that we are prioritizing them?
Thank you. Delegate McQuinn.
Thank you, sir. Thank you, Mr. Chairman. Dr. Abula, thank you, and the work that you all are doing. We do appreciate, and we know that you're navigating under some deep waters, and so we know the difficulties, but it still does not put us as legislators in a very good position when people are calling us and emailing and texting us. I do want to get to a couple of things that you said, and quickly. You talked about reallocation. And because of the Walgreens and CVS are not, I guess, fulfilling the duties that you were put out for them to do. So without fulfilling that task, I want you to be very, as you consider that, I hope we can get them to a point where they're doing what they're supposed to, because reallocating funds or taking the vaccines from from the drug pharmacies, which is more prevalent in Black communities than anything else, I think would create a problem where the community would not have access to the vaccine. To get to a place where, for those who don't have cars, who may have to catch a bus, we want to make sure that as you look at that you understand what taking the vaccines from out of the community in Walgreens and CVS. Every Black community I know got a Walgreens and a CVS in it. Then put some of the disadvantaged communities in a difficult place. And then the other piece is a lot, but I wanted to give you guys a suggestion. You got fire stations all over the place. You may want to give consideration to asking and see if they would get involved in terms of doing vaccines. They are trained for emergency services. They come up when you're having a heart attack, something much more egregious may be happening. They arrive on the scene. You may want to consider and see if they are willing to be partners in this Commonwealth to help support in the distribution or the allocation and distribution of these vaccines.
Thank you, Delegate McQuinn. It's some great suggestions, and I want to make sure you understand the CVS and Walgreens are not vaccines that are available in all of the CVS and Walgreens stores. They have mobile teams that are going into nursing homes and assisted living facilities. So there isn't really access through all the CVS and Walgreens right now. There will be eventually, but right now, as we prioritize the long-term care facilities, these are vaccines that the CVS team goes into a nursing home and vaccinates all of the staff and residents there. And so when we talk about reallocating away from them, all we're saying is the vaccine that's being held by CVS and Walgreens for that work inside nursing homes and assisted living facilities, we need other people to come alongside CVS and Walgreens so that we can do that more quickly. There will be a point, I anticipate, probably late February, early March, where pharmacies themselves have access to vaccine for walk-ins, but we're a ways away from that at this point. And then to the point of fire, you're right. I mean, in many communities have actually already used fire and EMS vaccinators to augment their vaccination staff, and that has been a huge help. We just had that going on in Henrico yesterday. We had a large vaccination event. I can't remember the final numbers. It was about 1,200 folks we were anticipating at the Richmond Raceway, but we were using vaccinators like Henrico EMS to help with that.
Well, I need you to help me to get one. I've been trying for 2 weeks to no avail.
I can definitely help you with that.
We'll talk about that later. Thank you.
Okay, any other questions? Okay, if we do not have any other questions.
Mr. Chairman, I had my hand raised up.
Oh, I see it now. Yes, sir, Delegate Ferris.
It's my understanding, Mr. Chairman and Doctor, it's my understanding that the virus is mixed and it's frozen before it's mixed. I've heard a lot of different stories about what happens to it, the lifespan of it when it's mixed and that kind of stuff. I brought up to our local fire departments last week before the it's funny how Delegate McQuinn and I are thinking alike, but I wanted to make sure, what they thought about it before I brought it up. And they were worried about the refrigeration and being able to keep the drugs and that kind of thing. Can you tell us what logistics might play into that?
Absolutely, Delegate Ferris. Thanks for bringing that up. So we have two different vaccine types right now. Pfizer and Moderna are the two producers of those. The Pfizer product requires what we call ultra cold storage. It has to be stored at negative 90 degrees Fahrenheit. And most places, most even doctors' offices and other providers don't have the freezer capacity to do that. Now, hospitals do. When we learned this back when Pfizer originally was coming out with this product, and we knew that was the case, many places ordered ultra cold freezers. So many of our local health departments have that capacity, and many of our hospitals have that capacity, but few others do. So that automatically drives a fair amount of your product to the places that can store it. Now, sending it to the places that can store it doesn't totally limit where it, how it will be used. So for example, we can set up partnerships where the hospital stores the vaccine and then distributes that out for usage on the days that vaccination is going to occur. Once out of the freezer, the Pfizer vaccine can be stored in the refrigerator and has to be used within 5 days before it loses its potency. The Moderna product has to be stored in a freezer, but not at severe temperatures, and most people have the capacity. So we've been trying to distribute the Moderna product much more widely. And then there are very specific things with this vaccine product that need to be taken into consideration. So for example, with the Pfizer vaccine, when you draw it up out of a vial, there's something called the diluent that you have to mix into it. And so you have to have somebody who knows what they're doing with that. And I'll be honest, a lot of practices have just not had the experience to do that. Now there are trainings on the VDH website. There's a lot of information for providers to be able to learn what they might be getting themselves into. But these are the things that the CDC is holding providers accountable, which is why there's a whole approval process that providers need to go through before they can be used as vaccination sites. So there are some complicated logistics, both in storage and in delivery. Also, it's a pretty fragile or friable vaccine product. And so if you shake a vial or drop a vial, you can't use it. And so we really, there's got to be some tight control out around how the vaccine is distributed and who's using it, and making sure they know all of these different important factors. As a point of interest, when you look at around what other states are doing, the places that have done this much more centrally, I think, have been able to control that more. The places that have distributed to a lot of other outlets have struggled to do that kind of quality control. And so right now, you're going to hear a lot of angst from doctors' offices and pharmacies who are saying, we see patients every day. We know how to vaccinate. Why can't we get the vaccine? The first answer to that is that there's not that much vaccine to go around. But the second answer is that the more that we can keep it controlled through sites that we know can do large scale vaccination, and we know we can rely on to reliably store, mix, and administer the vaccine, the quicker that we're going to get to the kind of numbers we need to see. And so now I think in these coming weeks where vaccine is scarce, we're going to continue to focus on those channels. But as I said, as we build towards 50,000 doses a day, we're going to need them all.
Okay, Delegate Ferris, you have a follow-up?
Yes, sir. Thank you very much, Mr. Chairman and Doctor. I appreciate that. That answers a lot of my questions about the mass places. I thought smaller places made more sense so that the virus wouldn't be spread. But how many doses are in a mix of diluted and the original product?
So the Moderna, the vial is 10 doses. I think the Pfizer, actually there's a new thing that came out from the CDC just today, and they're saying that you can now get 6 doses, where maybe you could previously get 5, something like that. Sorry, I should know the answer to this, but so the Moderna is 10 doses per vial. I don't have it pulled up on what the Pfizer is.
Thank you.
Thank you. Any other questions for Dr. Avula?
Delegate Torrin, Mr. Chairperson, I just like to make a comment. This is Delegate Tyler.
Delegate Tyler.
Thank you, Mr. Chair. Thank you, Doctor, for being with us today. But I just want to reiterate the fact that Delegate Ayers had expressed. I represent Southside Virginia, which is also in the Crater District, but a little town in Emporia, which is a hot spot with less than 6,000 population and one of the worst, is considered the one unhealthiest cities in the Commonwealth. I just want you to take note that it's important to get the vaccine to areas such as mine, but also it's so important too that that your department communicate with our emergency services people so we can be saying the same thing. Because in my district, we have a lot of problem with this miscommunications, and actually almost got into a fighting match with your staff. So I just want to convey that to you, and communication with emergency services and the health disparities in a little town called Emporia, Virginia. Thank you.
Okay.
Thanks, Tyler.
Thank you, all members, for your comments. And I think that we all have a better understanding of the challenges that we are being faced with this pandemic and COVID-19, and trying to get the vaccines out to the various communities in the Commonwealth. And Dr. Avula, I think that you've heard from our members that some of our most needed communities is seemingly being neglected. And we certainly hope that we will begin to focus some attention on some of these communities that the members have mentioned to you this afternoon. And we will certainly be in touch with you. And I'm sure that I want to encourage the members as you continue to receive comments and feedback from your respective communities, please pass it on to me, and I will make sure that Dr. Avula and the Department of Health here will hear your concerns, and we will be in a position where we can monitor the progress that should be taking place in some of our underserved communities. So again, Dr. Avula, I thank you for being with us today. Members of the committee, this concludes our meeting with Dr. Avula. I do want to ask all of our subcommittee chairs to remain on this Zoom call. I have a few things that I need to share with you in regards to us moving forward beginning next week and some of the work that will be before you all. So,
Mr. Chairman?
Yes, ma'am.
I'm sorry, I believe House IT needs this link, but they have another link that has been sent to the subcommittee chair.
Okay, so we all need to terminate this link and look at your email, subcommittee chairs, and let's get on a call immediately, please. This concludes our meeting.
Thank you all. Take care.